you're interested. So looking back at this map, I just want to point out that this is an analysis of areas where there's high levels of unmet need for family planning and rapid population growth. And these are often countries that have low resilience to climate change, as well as high levels of projected decline in agricultural production. So that's certainly an area to bring in farmers and men into the discussion. This slide is a quick slide that specifically looks at these issues in sub-Saharan Africa, and I will draw your attention to Madagascar because you will be having a much more detailed discussion of Madagascar in a few minutes. So that's an area of high population, with high population growth rates, as well as low resilience to climate change. So another interesting rationale behind these projects is the moral rationale. It's the right thing to do, right? These are remote populations from urban centers as well as economic centers, and they're very marginalized. So just to give you a sense of the foundation behind these projects, it really comes from ICDP, or the Integrated Conservation and Development Programs, from the mid-80s that brought together alternative livelihoods and conservation efforts. If you are interested in these integrated PHE projects that I'm referencing, Population Reference Bureau has a map. I'm sorry I didn't include it in my presentation, but it shows where throughout the world these projects exist. And you'll actually see some links to some of the projects that I mentioned here in my presentation, as well as the ones that Gildas will be presenting. And actually that's it. I again want to point your attention to some of the publications that I brought. I wanted to encourage you to take a look at our website as well as our blog, and you can find more information about those exact addresses there. We obviously have a presence on Facebook and Twitter, since we know that's the thing to say these days. The video that I didn't showcase was part of our YouTube channel, so you can definitely search for us there. And the one thing I wanted to point out is that, you know, being an international policy think tank in Washington, D.C., we put a lot of such presentations together, and they're often webcast. And so if you're interested in seeing more about these, you can take a look at some of the archived ones on our website as well, including some presentations that some colleagues of Gildas's have done on Blue Ventures efforts in Madagascar and DC. So thank you.
So, good evening everyone, and thank you for coming to this session. And as she said, I'm Gildas Malale from Madagascar, working for Blue Ventures Conservation. And I'm going to present our work about PHE in the ground here. And by the way, I'm on the E part of the project, so nothing to do with population and health, but I'm just trying to explain everything here, so if any question at the end, I'd be happy to respond to it. Thank you. And so the overview of this presentation, I'm going to talk about all of the Blue Ventures program first, mostly the conservation part, and then our goal and the population and demographics of the site, basically, and population and the health activities that we are undertaking on site. So Blue Ventures is based in the southwest of Madagascar, in a place called Andavadoka, and we work with 25 village communities. And first of all, we are doing conservation, help community to manage their resources, but also help this community to improve the quality of their life. And just some characteristic of the southwest of Madagascar, we have one of the Indian Ocean largest reef system, so very rich in marine biodiversity. And the site is populated by the Vezo people, the Vesi people, which is one of the tribe, the 18 tribe in Madagascar, who spend their entire life in the sea for food, transportation, trade, and everything. And women, kids, and men all go for fishing. And but the area is threatened by, first of all, the main problem is the poverty, and it's very remote. From the nearest town, you have to take 8 hours or 4x4 to get there. And a few livelihood alternatives. Everybody is relying on the natural resources from the sea for the livelihood. And of course, our subject today, there's an enormous demand for sexual, reproductive, and health services in the area. And let's talk about a little bit about the population statistic in Linkages. Linkages is the name of the locally marine managed area that I'm going to talk about next. And of course, it's a very young. Sandy was talking about 20 years old earlier, 25, I don't remember, but in the area we are working on, there is about 53% of the population under 15 years old, and very high infant and maternal mortality rates. We're going to talk about that. So, and one family has about 6.7 children per woman, which is very, very high. And of course, the population doubling in the span of 15 years. So what Blue Ventures did these last 12 years is we helped create the Linkages LMMA. As I said earlier, we are based on the conservation first management of their resources. And the LMMA is a combination of 25 villages along the southwest coast of Madagascar. And what we did is just help community build capacity for them to be able to manage their resources. And at the moment, they have a series of permanent reserve. Some areas that they close, and they closed it a forever reserve, by the way. It's a piece of coral reef that they close, and a mangrove reserve also. And since 8 years now, they are doing temporary fisheries closure, mostly of octopus, which is the most valuable resources from the area. And also, as an alternative livelihood, we work together with them for farming seaweed and sea cucumbers, which create financial benefit from the community. And a very, very big project about education with UNICEF these last 3 years. But what we're going to talk about more today is what we are doing on family planning and community health program. The program is called Safidi. Safidi means choice in Malagasy. So that was the name at the beginning we created to tell people the messages of they have a choice to choose how many kids they have through contraceptive method, and how they can plan it in general, the year when they want to have their kids. And Sandy was presenting about this link between the PHE, and what I'm going to show you is how does it work on site. And it's probably for all of the developing countries, but specifically in the area we work on. First of all, population are very poor, and that leads to family size based on quantity. There is, even when we do survey why they do have lots of kids, some of them reply that because there's a chance that 1 or 2 of them will die and the others will replace it. And that's why it's really based on size, quantity. Or some of them say that, you know, when we are old, we're gonna have a lot to look after us. If you have 8, for example, and that leads to high population growth and more demand for resources. Of course, degrade environment, And again, lack of natural resources, and come back to the poor health, and we are targeted conservation and development. We don't meet it at the end. And what we try to do is the positive feedback with community having good health, family size based on quality, low population growth, less demand for natural resources, and healthy environment. And again, leave more natural resources, enough for everybody. And in that way, we can meet our goal of conservation and development. So what Blue Ventures tried to do these last years is for the health, we focused on the maternal and child health, and also with the WASH project, the sanitation, hygiene, and water, sanitation, and hygiene. I'm sorry. And for the population, of course, the family planning project, and Linkages for the environment, the LMMA that I was talking about. So let's talk first about the family planning. The family planning, we do it with the CBD, the community-based distributor. So we train. It's as Sandy said, it's all about voluntary work. They don't get money from it. They just get money from whatever they sell, a very, very little amount of money. So we train them about the contraceptive method and distribute it to them. And in every village there is a CBD. And in that way, we don't have that many staff to take care of it. So it's very cost effective to use the local people. And we have it in 3 different sites. The blue one there, it's Linkages. Here, the green one is an inland park run by the Madagascar National Park in the forest. And the one down here is a LMMA run by WCS. But we agreed with each other for us to work in these 3 sites. And just these are the contraceptive methods offered, the long-acting method, permanent acting, and the short-acting method. And sorry, you saw the PSI logo there. We work together with PSI with the long-acting and permanent method. And we have clinic technicians from the community as well that we train and visit to see what's happened in every single village every week or every 2 weeks. And here, for example, is a PSI. It's a PSI doctor coming on site for anybody who wants the long-acting and permanent contraceptive method. And just an example of each of that. So I'm going to talk about the number of patients visited. We started this project late 2007 and 2008, I think. And that time we had only 226 women, and it was only in 1 village that time. And that's the only reason I can talk about this today, because that time we didn't even have a Malagasy doctor. We had a foreigner coming to site, and we had to translate for the woman, and we were the translator on site. So it's very hard to talk about sexual things to women, but that's how we see that they accept it. It's something they need. They even allowed myself, a man, to translate for them about their social health, about their health and family planning, which is very, very awkward. And sorry, in year 2, we had 313. In year 3, we had 1,000 or more. Year 4, it doubled. And year 5, we have 3,335. And that was the last data in 2011, I think. So now 2012, it went up again. And So just a numbers of what we've been distributing all of these years. I'm not going to go through it, but it's pretty much everything. And talking about the contraceptive prevalence rate, it was 10% before our intervention. And late 2010, it went up to 25, and early 2011, 35%, which is above the 20% regional statistic in Madagascar, in the southwest of Madagascar, sorry. And we're gonna transform that to a couple years of protection, something that I'm not really familiar with, but what I know is that number means that approximately 589 unwanted pregnancies were prevented in the area. And in another perspective, if those 589 births had occurred, the regional population will be about 5.5% larger. This is a very, very specific calculation from UNFPA, or also I'm not really familiar with, but when I see it, I know that there was a success and an improvement on site. So that's all about the family planning first, and now let's move quickly to the water sanitation and hygiene. This is a project we've been doing the last 2 to 3 years, if I remember. And what we do is all about education, and we have these 8 topics: the clean water, dairy, using latrines, and trash, hand washing, oral hygiene, waste management, and food handling. And what we do, we have 2 agents. They travel around the site and run village outreach tour, and also they work together with schools to teach kids about everything that I mentioned before, and also show videos to villagers and just talk to villagers. And also they implement youth clubs in each area where they work, to just leave the message there, and those guys are in charge of spreading it when they leave. And so we have a radio program, and we also distribute products for the community. For example, here, this is the things we call tip tap here. You just need a few amount of water to be able to wash hands for hand washing unit, and also bars of soap, toothpaste and brushes for the students, the kids, and distribute water treatment solution and diarrhea treatment for the communities. And all of that, they all don't cost that much, all of these products, and we work together with, I think it's a PSI also that they work together with us to provide that. And we work on a well construction project. It's very tough in the area where we work, because there's, amongst all of these 25 villages, there's only 3 or 4 that you can find fresh water. The rest are all salty water, which is very, very bad. And we did it only for 2 villages until now, but we're still progressing on that. And of course, we also work with the CBDs again, train them about wash, and they are in charge of distributing all of these things I was talking about in every villages. And this is a project we just started 4 months ago. In my area, that's the over picture over there that always happens, which is, of course, very bad, as we all know, for the hygiene and the health of the sea and everything. So now we working on this CLTS campaign, working to stop on open defecation with community. And so this is a very, very strong and very difficult subject. It's something that you're not able to talk about in front of people. When you ask them why do they do that, they will tell you that that's the custom, that's the culture. We don't want to do that in a house. That's the way they answer it. But we started with the leaders first. You know, the leaders, those are the ones who's willing to change first, and train them about the CLTS for 25 leaders. We tried it only in 1 village. If you work in 1 village, we're gonna spread it, same as the way we did everything from the beginning. Yes, that's all about what I can talk about with the WASH. And the final one is the maternal and child health project. And this is a statistic we got from UNFPA on Madagascar. So it's a very, very big problem on site. So what we try to do with a survey for the child, these are everything that can be done for the child to avoid this infant mortality. And so what we try to do, we're gonna try to work on all of this. And from the survey says that it's a very, very, very big problem on site. All of these problem, and I mean, it doesn't really exist on site, all of these methods to avoid this child mortality, from breastfeeding, clean delivery, going to the doctor, having a birth certificate, vaccination, all of that. And for the mother, we did the same way. It's access to family planning, of course, and seeing a doctor is